Hi guys, welcome back. So today we are going to talk about heart failure. So first of all, let's define what heart failure actually means. So heart failure simply means that the heart isn't able to supply enough blood to meet the body's demands, okay? So heart failure, the heart is failing. Why is it failing? It's not able to supply enough blood to meet the body's demands, okay? And this can happen in two ways. So the heart can fail in two ways. So there's two types of heart failure. We have systolic heart failure and diastolic heart failure. So systolic heart failure is a pumping problem. So in systolic heart failure, the heart isn't able to pump enough blood to meet the body's demands, okay? So systolic heart failure, again, is a pumping problem. It's not pumping enough blood. Diastolic heart failure, on the other hand, is a filling problem. So a filling problem means that the heart isn't filling with enough blood, okay? So if you're not filling the heart with enough blood, then you're not really gonna eject enough blood as well, okay? So the heart can fail in two ways: systolic heart failure and diastolic heart failure. In both cases, they lead to the blood backing up to the lungs, and I'll explain this more in a bit. So if blood backs up to the lungs, it causes pulmonary edema and therefore congestion in the lungs, okay? This is why this type of heart failure is called congestive heart failure, okay? Because the blood is backing up to the lungs, causing pulmonary edema and congestion, which then leads to other problems like dyspnea, because when you have lots of fluid in the lungs, that increases the distance for gas exchange, so it makes gas exchange very inefficient, and therefore the patient struggles to breathe, okay? So heart failure can happen in either side of the heart, so it can happen on the right side or the left side. That's why we have right-sided heart failure and left-sided heart failure, and it can actually happen in both as well, called biventricular heart failure. So the right and the left side of the heart can have either systolic or diastolic heart failure. And the terms left-sided and right-sided heart failure simply pertains to which problem happened first, okay? So it basically defines or describes which problem, which side of the heart was affected first, okay? So that's just why we use those terms. But because the left and the right side of the heart are connected in a series fashion, right side heart failure can lead to left side heart failure and vice versa. So left side heart failure can also lead to sided heart failure. So again, the terms left-sided and right-sided just pertains to which was the primary problem. So let's first talk about systolic heart failure. So systolic heart failure, as I've already said, it's a pumping problem. So the heart isn't pumping enough blood to the circulation. So recall that the heart has to pump a specific a volume of blood to supply the whole body with blood to meet its demands, okay? So this is called cardiac output. So cardiac output is the amount of blood that the heart pumps per minute. And recall that the equation for cardiac output is heart rate times stroke volume. Heart rate is just how many times the heart beats per minute, and stroke volume is the volume of blood that gets ejected from the left ventricle per heartbeat, okay? So cardiac output is basically heart rate, how many times the heart beats per minute, times stroke volume, which is the volume of blood ejected per heartbeat. So let's just give an example. So for instance, our heart rate is 70 and our stroke volume is 70 mils per heartbeat. So this means we have 4,900 milliliters of blood pumped out per minute. So this is our cardiac output. And so though that 70 milliliters of blood pumped out in the left ventricle per heartbeat isn't the total amount of blood in the ventricle, okay? So this is called the ejection fraction. So basically, we've pumped out 70 mils of blood from the left ventricle, but that's not the total amount of blood that is in the left ventricle. Some of that gets actually left behind. So the total volume of blood in the left ventricle would be closer to around 110 mils, okay? So if we have 110 milliliters of blood in the left ventricle prior to contraction, and then when we contracted during systole, 70 mils of that blood gets pushed out into the aorta, into the systemic circulation, then we're left with 40 mils of blood in the left ventricle. So if we calculate ejection fraction, which is the volume of blood that has been pumped out divided by the total volume of blood in the left ventricle, it would be 70 divided by 110 mils, that's around 64%. So this is our ejection fraction. And this is very, very useful because systolic heart failure is basically defined by really, really reduced ejection fraction, okay? Because ejection fraction tells us how much of that blood in the left ventricle is actually pushed out into the circulation. So if we have 64%, that's normal. So the normal ejection fraction is between 50 to 70%. So 50 to 7% is normal ejection fraction. So in this case, you have 64%, so that's normal. If it falls below 50, that's reduced ejection fraction. If it falls below 40%, we have a systolic heart failure, okay? So systolic heart failure means that we have 40% or less ejection fraction. This is why it's important to calculate ejection fraction in terms of defining systolic heart failure. So what actually causes systolic heart failure? So for systolic heart failure, I want you to think about the heart as being very, very dilated, very floppy. It's really struggling to contract enough to push that blood out. Actually, before we get into the causes of systolic heart failure, let's first review or revise what actually influences stroke volume, because we know that systolic heart failure means we have a very low stroke volume, okay? We're not pumping enough blood per heartbeat. So the things that influence stroke volume are contractility. So how hard does the ventricles actually contract? How much is that force of contraction, okay? So that's contractility. And the higher the contractility, the higher the stroke volume, and therefore the higher the cardiac output. The second factor that influences stroke volume is the preload, okay? So the preload basically refers to the stretch of the heart. So it depends on venous return, how much blood returns to the heart, and how much filled the heart gets, how much stretch the heart gets prior to contraction. So the higher the preload, the more the heart becomes stretched out and filled out with blood, the more the stroke volume will become, okay? So higher preload means higher stroke volume, which then means higher cardiac output. The last one is the afterload. So the afterload refers to the resistance, or basically how difficult it is to pump blood out of the heart. So that's basically influenced by the arteries, how resistant they are, and how vasoconstricted they are. So it refers to the degree of vascular resistance. So if you increase afterload, what is that going to do? That's going to make it more difficult for the heart to pump the blood out, okay? So increased afterload means decreased stroke volume, means decreased cardiac output. So just to go over that again, the three factors that influence stroke volume are contractility. So the higher contractility, the higher stroke volume. Preload. So the higher the preload, the higher the stroke volume. Afterload. The higher the afterload, the lower the stroke volume. So it's only afterload that's inversely proportional to stroke volume. Right. So now let's actually discuss the potential causes, or what factors may lead to systolic heart failure. as I mentioned previously, for systolic heart failure, I want you to think of the heart as being very, very dilated, very floppy, very big, very hypercompliant with very thin walls, and therefore very weak contractions. So the causes of systolic heart failure can be an ischemic heart disease, for example, like an MI, a myocardial infarction, especially an inferior MI or a lateral MI. So basically an infarction located in the left ventricle. So what happens when we have ischemia or an infarct in the left ventricle? So this affects the cells. So if there's ischemia, then there's less supply of oxygen, then these cells die, and when they die, obviously they can't perform their normal function. So this means that those cells won't be able to contract as forcefully, and therefore it would weaken the contractility of the heart. Okay, so an ischemic heart disease or an MI can lead to systolic heart failure because the cells are damaged. They can't do what they're supposed to do. They're not going to contract as forcefully as the other cells, which are normal. Okay, and second one could be dilated cardiomyopathies. So dilated cardiomyopathy is just any disease that can lead to the heart being dilated, So, for instance, there's so many causes. This can be bacterial, this can be viral, this can be idiopathic, autoimmune, can be due to cancer. So essentially, for dilated cardiomyopathies, what happens, regardless of the cause, what happens to the heart is it becomes very, very big. The chambers become very, very big, very dilated, which means that the chambers actually become enlarged, but then the walls, they become super, super thin and therefore unable to contract as forcefully, okay? So that's what happens when you have dilated cardiomyopathies. And another potential cause of systolic heart failure is valvular diseases, okay? So let's say, for instance, we have mitral regurgitation. So mitral regurgitation, so the mitral valve is the valve between the left atrium and the left ventricle, right? So if we have mitral regurg, during systole, instead of that mitral valve shutting, preventing backflow to the left atrium, what happens is it reopens and some of the blood actually goes back to the left atrium. Okay, so that means that blood is just accumulating in the left atrium, and over time what happens is this chamber becomes dilated. It becomes bigger and bigger and bigger, and the walls become thinner and thinner, and therefore again you're reducing the ability of that chamber to actually pump as forcefully. Okay, so valvular diseases like mitral regurg and aortic regurgitation does the same thing. So this influences the left ventricle. So the left ventricle, because blood is backing up to the left ventricle every time that the left ventricle contracts, because we have a regurgitant aortic valve, the left ventricle just becomes bigger and bigger and dilated, more and more dilated. The walls become weak and it's unable to contract blood as forcefully as if we didn't have that valvular disease, okay? And finally, one of the other potential causes for systolic heart failure is long-standing hypertension, right? So recall that stroke volume is affected by afterload, right? So if we have hypertension, we are increasing our afterload, because in the case of hypertension, we have a greater arterial resistance. So we have a greater vascular resistance, okay? So that increases afterload. It makes it more difficult for the heart to actually pump that blood against that greater resistance. So what happens then to compensate is that the left ventricle, because the peripheral resistance, the vascular resistance is so high, what the left ventricle does to compensate is it becomes bigger. Okay, so it undergoes hypertrophy, becomes bigger. But again, This is the heart's attempt to be able to generate more forceful contractions against that high resistance. But what happens over time is that this actually becomes a problem, because when the heart hypertrophies, when the heart becomes bigger, it makes more cells, more heart cells. And more heart cells mean more demand of oxygen to the heart. Okay? And as the heart actually becomes bigger, it squeezes those coronary arteries, which means that now we have even less supply of blood to the heart muscle. So we have a supply and demand problem again in the heart. So we have increased our demand for oxygen and for blood because we have created more heart muscles to be able to pump more blood out. But that increase in demand for oxygen is not being met because we're squeezing those coronary arteries to the point where they are not really able to supply enough blood to the heart muscle. So some of those heart muscles eventually become weak, and therefore they are not able to generate forceful contractions, leading to systolic heart failure. All right, so just as a summary, things that can potentially cause systolic heart failure include, so we started talking about ischemic heart diseases like MI, especially inferior and lateral MI, and dilated cardiomyopathies for whatever reason, viral, bacterial, autoimmune, cancer. What's the third one? So valvular diseases like mitral regurg or like aortic regurgitation, because that just encourages the accumulation of blood in the chambers, which then makes the heart more and more dilated. Their walls become thinner and then less forceful contractions, okay? And the last one is something to do with the afterload. So the last one is long-standing hypertension. With hypertension, we increase our afterload, which means that it's going to be harder to pump blood out, reducing our stroke volume. And because we have the supply and demand problem, again, the heart muscles are not getting enough oxygen, therefore they are not going to contract as forcefully. So those are the 4 potential causes of systolic heart failure. Now let's talk about diastolic heart failure. So diastolic heart failure is a filling problem. So the heart isn't filling with enough blood prior to its contraction. So in diastolic heart failure, the ejection fraction may be preserved, or it may even be normal. So for instance, let's say that we are only pumping 44 mils of blood from the left ventricle, right? So our stroke volume is 44 mils per beat. However, our total volume is also very low. So instead of it being 110 mils, now our total volume in the left ventricle is only 69 milliliters. So we're pumping out 44, the total volume is 69. So if we calculate ejection fraction, 44 divided by 69, it's actually around 64%, which puts us in the normal ejection fraction range, okay? Recall that normal ejection fraction is at least half, 50% to 70%. Sorry, in this case, we have 64%, which is a normal ejection fraction. So it's normal because we have the total volume of blood is also low, okay? And therefore, the amount that we're ejecting is not going to be very high. It's also going to be low. So diastolic heart failure is not a problem with ejection fraction. Ejection fraction can be preserved. It can even be normal. But the main problem here is that the chambers of the heart are not filling with enough blood. So we have reduced preload, okay? We're not stretching the heart enough. We're not filling the heart enough prior to each contraction. We have low preload, and this is the problem with diastolic heart failure. Okay, so before we talk about the causes for diastolic heart failure, I want you to visualize a heart that's very, very stiff. It doesn't want to stretch. Okay, so it's very stiff, it's non-pliable, it's non-compliant. It just doesn't want to stretch out, basically. So that's the kind of heart we have when we have a diastolic heart failure. So the first potential cause of diastolic heart failure is, again, ischemic heart diseases. So for instance, if we have an MI, so if we have a myocardial infarct, the cells would have been ischemic and then they would have died, meaning that they're not gonna perform their function so well. So if we have ischemic cells, or cells that have died and have been replaced with scar tissue, that scar tissue isn't gonna be very stretchable, isn't gonna be very pliable, okay? Meaning that it's not gonna stretch out as much. Again, leading to the heart being very, very difficult to fill with blood, okay? So that's one of the potential causes of diastolic heart failure. The second potential cause would be restrictive cardiomyopathy, so restrictive heart conditions. So, okay, the one thing I can think of is amyloidosis. So this is a buildup of protein called amyloid. It just accumulates and builds up in like organs and tissues, including the myocardium, making it very, very difficult for the heart to stretch, okay? So because of that buildup of protein, it reduces the stretchability of the heart, leading to, restrictive cardiomyopathy, leading to, the heart being very restricted in the sense that it's not going to fill with enough blood. It's going to be fibrotic. It's going to be very, very stiff, okay? Another cause of this restrictive cardiomyopathy, okay, so we could get a buildup of iron, so hemochromatosis. And we can also, for instance, if you have cancer and we're getting radiotherapy, radiotherapy damages those cells, and if they're damaged, they die and they get replaced with tissue that's not very, very good, that's not very stretchable, making it again difficult for the heart to stretch. Also, constrictive pericarditis can be another one, and a more acute one can be like cardiac tamponade. So in cardiac tamponade, because we have fluid in the pericardium, the ventricle isn't gonna stretch out as much, and therefore it's not gonna fill it with a lot of blood, okay? Okay, that's it for restrictive cardiomyopathies. And finally, long-standing hypertension can also lead to diastolic heart failure. So with hypertension, again, we have an increased afterload. We have an increased resistance that we need to overcome to pump blood out of the ventricle. So what the left ventricle does to compensate is it hypertrophies, more specifically concentric hypertrophy, meaning that the wall becomes thicker and thicker and thicker, okay? So when the wall becomes thicker and thicker, it kind of crowds into the chamber space, making that chamber space very, very small, meaning that the heart, or that chamber, isn't really gonna fill with a lot of blood, okay? So again, leading to a filling problem, leading to a diastolic heart failure. So again, to recap, diastolic heart failure causes include ischemic heart disease like an MI, because it impairs the ability of those myocytes to expand and stretch. And then the second is restrictive cardiomyopathies, whether that is because of amyloidosis, hemochromatosis, constrictive pericarditis, cardiac tamponade if it's acute, things like that. And the third one is hypertension, okay? So we've covered diastolic and systolic heart failure. Now I want to cover left and right sided heart failure. So like I said at the beginning, systolic and diastolic heart failure can occur in either side of the heart. It can occur in the left side or the right side of the heart, and or both sides of the heart, leading to biventricular heart failure. And because the left side and the right side are connected in a series fashion, right-sided heart failure can cause left-sided heart failure and vice versa. Firstly, let's discuss left-sided heart failure. So left-sided heart failure is usually a pumping problem. It's usually a systolic problem. So recall that we now know some of the causes of systolic heart failure, including ischemic heart diseases, dilated cardiomyopathies, long-standing hypertension, and valvular diseases. So I'm just going to go over this really, really briefly. So again, left-sided heart failure is usually a pumping or a systolic problem, okay? So causes include ischemic heart disease. So for instance, if we have coronary atherosclerosis, then some of the cells like proximal to that plaque may receive less oxygen and less blood, and therefore they may die. And once they die, they become scar tissue, and scar tissue doesn't contract at all. So the ventricle would have weaker contractions. Also, if we have an MI, specifically like inferior lateral MI, because that's the left ventricle. So again, myocardial infarction means that some of those cells have died, and therefore they're not going to contract as forcefully, okay? And the second one is dilated cardiomyopathy. So dilated cardiomyopathies, whether that's viral cause, bacterial, autoimmune, cancer, alcohol, or idiopathic, doesn't matter. But the idea is with dilated cardiomyopathies, the left ventricle expands, it becomes bigger as an attempt to fill the ventricle with more blood so that more blood can be ejected out, okay? But this doesn't work in the long run. So over time, what happens is the left ventricle becomes very, very dilated. The walls become very, very thin, and therefore it's not going to generate as forceful contractions, okay? So the third one is valvular diseases. So if we have like mitral regurg or aortic regurgitation, again, that leads to the dilation of the left side of the heart, causing left-sided heart failure, because with that dilation, the walls become thinner and weaker, and we're not going to generate enough contractions to pump enough blood out of the heart, okay, leading to left-sided heart failure. And finally, long-standing hypertension. So if we have hypertension, we have high afterload. That means the left ventricle has a much higher pressure to overcome to pump that blood, making it more difficult for that for the left ventricle to pump blood out, because we have such a high resistance. So this is what hypertension does. And as a compensatory mechanism, what happens is that the left ventricle hypertrophies, okay? So when it hypertrophies, it basically produces more cells, and more cells mean that there's a greater demand for blood and for oxygen, because now we have more cells working. But when that left ventricle actually expands and becomes thicker, that squeezes the coronary arteries, meaning that it's not gonna supply as much blood. So we have a higher demand but less supply of oxygen and blood, meaning that some of those cells would be ischemic, they would die, and they are not going to generate forceful contractions. So those are the potential causes of left-sided heart failure, which is typically a systolic or a pumping problem. So now let's briefly discuss some of the symptoms of left-sided heart failure. So first of all, because blood is going to back up to the lungs, we are going to have pulmonary edema and congestion, and this will lead to dyspnea, because when we have pulmonary edema, it's going to alter like gas exchange. It's because we have more fluid there, which isn't normal. We're going to increase the barrier for gas exchange, making it more difficult to exchange gases, making it harder for the patient to get enough oxygen, leading to dyspnea. They can also get orthopnea, which is just shortness of breath when they lie down. So a classic presentation of like heart failure would be like the patient would need to be propped up a lot, when they go to bed, because they can't stand lying down, because that makes them, that gives them shortness of breath. Also, when we auscultate, we can hear crackles. So we would hear like bibasal rails or crackles. Also, we can get hemoptysis or coughing up blood, because we are overloading the pulmonary vasculature with a lot of blood. As the blood is backing up to the lungs, we're overloading the pulmonary vessels with a lot of blood. And when they get to the capillary end, the blood's just gonna ooze out. It's gonna get pushed out. So blood basically goes into the alveoli, and sometimes the patient can cough that up, leading to hemoptysis. Or the alveolar macrophages in the lungs can eat up those red blood cells, leading to them taking on this like brownish tint, this brownish color, because of the iron buildup from the red blood cells. And it's called something like hemosiderin laden macrophages or something. But basically, the alveolar macrophages, they change in color, so they become more brownish as they, engulf the red blood cells in the alveolar space. So those are some of the symptoms of left-sided heart failure. And in terms of treatment, so we can give them ACE inhibitors. So ACE inhibitors, basically, they dilate the vessels. Okay, I don't want to go into pharmacology, but I just want to tell you what ACE inhibitors do and why they help. So ACE inhibitors, they dilate the vessels, basically reducing the workload that the left ventricle has to put in by decreasing the resistance that the left ventricle has to pump against. Okay, that's why ACE inhibitors are very, very effective in left-sided heart failure. Also, we can give them diuretics. Diuretics just to flush out the excess fluid, reduce the edema. That's it. So that's everything for left-sided heart failure. So moving on to right-sided heart failure. So right-sided heart failure is commonly caused by left-sided heart failure, because recall that in left-sided heart failure, we are backing up blood to the lungs, increasing the blood pressure in the lungs, so creating pulmonary hypertension. And this pulmonary hypertension due to left-sided heart failure makes it very, very difficult for the right ventricle to pump blood through the pulmonary arteries and into the lungs, because it has such a high resistance, has such a high pressure to overcome. And then this then leads to that right ventricle failing over time because of this increased resistance, okay? That's why right-sided heart failure is often caused by left-sided heart failure. But we can also get isolated right-sided heart failure. So right-sided heart failure that happens not because of a pre-existing left-sided heart failure. So for instance, if we have left to right shunts. So left to right shunts like congenital problems like ASD, a VSD, an ECD, a PDA. So in these cases, blood is shunting from the left side of the heart to the right side of the heart, okay? So this means that we are shunting a lot of blood volume from the left side of the heart to the right side of the heart, overloading that right ventricle with a lot of volume, okay? So over time, what happens is it becomes very, very dilated, and the walls become very, very thin, okay? And this makes it very floppy and not very forceful when it contracts, so leading to right ventricular failure. Also, another potential cause of an isolated right-sided failure is chronic lung disease. So in chronic lung disease, because gas exchange is impaired, the body is in a hypoxic state. So this hypoxia triggers a reflex response. So it triggers the vasoconstriction of pulmonary arterioles. And if we constrict our pulmonary arterioles, what that does, it raises pulmonary vascular pressure. It raises pulmonary blood pressure. So with increased pulmonary blood pressure, it actually makes it difficult for the right ventricle to contract blood, to push blood to the pulmonary circulation, because it has such a high pressure, such a high resistance to overcome. So initially what happens is concentric hypertrophy happens within the right ventricle. So it hypertrophies, it creates more cells, in an attempt to make it easier for it to pump blood out against that high resistance. So this concentric hypertrophy of the right ventricle means that there's an increased demand in oxygen because there's more cells, but because of that, that actually squeezes some of the coronary arteries, meaning that there is a decrease in the supply of blood. Okay, so that's what happens initially, and over time, again, it just becomes dilated and floppy and weak, leading to right-sided failure. So those are the causes of right-sided heart failure. So just to recap, the most common one is left-sided heart failure because of that increase in pulmonary pressure, increase in pulmonary hypertension. And then causes of isolated right-sided failure can be due to left to right shunts. So if we have like an ASD or a VSD, a PDA, anything that would shunt blood from the left side to the right side, overloading that right side, can lead to right-sided heart failure. And the last one is chronic or long-standing heart disease. So I forgot to mention that if we have a chronic lung disease that leads to right-sided heart failure, we actually call this as cor pulmonale. Okay, cor pulmonale is when chronic lung disease leads to right-sided heart failure. In terms of symptoms of right-sided failure, what happens is blood backs up to the systemic circulation, okay? Because it's harder for that blood to be pushed to the pulmonary circulation, it backs up to the systemic circulation, in the veins of the systemic circulation. And this can be manifested in multiple ways. So firstly, we can get blood backing up to the jugular vein. So we get jugular venous distension, and we can get blood backing up to like some of the organs. So like the spleen and the liver, causing splenomegaly and hepatomegaly. And if the liver has been congested for a while, this may even lead to liver cirrhosis and liver damage. And it can also back up to the peritoneal space in the abdomen, causing ascites. It can even back up to the interstitial space in the soft tissues of the legs, causing pitting edema. In terms of treatments, because it's usually caused by left-sided heart failure, we use the same treatments. So we can use ACE inhibitors to dilate the vessels, making it easy for that left ventricle to pump blood by reducing the workload for the left ventricle by dilating those vessels, making it easier to pump blood. The second can be diuretics to reduce the fluid buildup, to reduce the edema. I also want to add that there's a difference between concentric hypertrophy and eccentric hypertrophy. So concentric hypertrophy means that the heart makes more muscle cells in parallel with each other. So this causes like the thickening of the wall to the point where it crowds the chamber space, making the chamber space smaller, which means that less blood actually gets in, a reduced volume of blood gets into the heart, causing a diastolic dysfunction. And eccentric hypertrophy means that the heart gets dilated. So the chamber space actually enlarges, but the walls become thinner. And therefore, this causes a systolic problem because the walls are too weak to generate forceful contractions. In any case, in any hypertrophy case or in any heart failure case, the heart cells get irritated. So what actually happens is, because they're very irritated, they can cause arrhythmias. The heart can develop arrhythmias or abnormal heart rhythms. And this can extend to the point where the ventricles are not contracting in sync, making them very inefficient in terms of pumping blood throughout the body because they're not contracting in a synchronized manner, which then worsens their heart failure. So now we're in a very, very bad situation. So in this situation, the patient can be referred to have like a pacemaker fitted in so that the ventricles can contract in a synchronized manner again, helping the heart to pump blood more efficiently to the circulation. Or they can be fitted with an LVAD, or a left ventricular assisted device, which basically just helps the left ventricle pump more blood, okay? Or if it's like the end stage heart failure and we've tried everything, the only hope would be a heart transplant.